Welcome to Managing Anticoagulated Patients with Obesity, a focus on direct oral anticoagulants, a joint continuing medical education program brought to you by the North American Thrombosis Forum and CNCS-CME. This program will address the complexity of managing patients with obesity who require anticoagulation, with a particular focus on the use of direct oral anticoagulants. As obesity has become increasingly common, how to best treat these patients with anticoagulation is a frequently encountered clinical question. In this program, speakers from several subspecialties such as endocrinology, cardiology, hematology, and bariatric surgery will review the current medical literature on DOAC use in patients with obesity and provide their unique perspectives to address this question. The program will conclude with a case-based debate and Q&A session to facilitate interdisciplinary discussion and provide insights on best management strategies. This program has been designed for physicians, nurse practitioners, physician assistants, pharmacists, and other clinicians specializing in cardiology, emergency medicine, endocrinology, family medicine, hematology, oncology, hospital medicine, internal medicine, surgery, and vascular medicine. At the completion of this activity, the participant will be able to describe best practices for defining and measuring obesity and the complexity revolving around the management of obesity, recognize the unique clinical challenges that may impact DOAC use in patients with obesity, review the latest data on indications for DOAC use in patients with obesity, including atrial fibrillation, VTE, and in the setting of bariatric surgery. Review and identify limitations of various guideline recommendations pertaining to DOAC use in patients with obesity. Assess optimal prophylactic and therapeutic anticoagulation strategies in patients with obesity. The content reviewers have no conflicts of interest to disclose for this activity.
Welcome to the North American Thrombosis Forum CME program entitled Managing Anticoagulated Patients with Obesity, Focus on Direct Oral Anticoagulants. My name is Zufei Wang, and I'm a hematologist and associate professor in the Division of Hematology at University of Ottawa and an associate scientist at the Ottawa Hospital Research Institute. My clinical research interest is clinical research in optimal prevention treatment in patients with VTE, cancer-associated thrombosis, and obesity-associated thrombosis. I have the pleasure to chair this program for you today, and I'm very excited about this program. We have a great program, and I thank you for joining us, and I hope that we will provide very great information for you, and we will have plenty of time at the end for question and answer. Hopefully we'll generate a very good discussion. I would like to thank NATF support and all the speakers up front for their time and effort to put together this great program. So before we started, I just have a few general announcements. This program is presented by the North American Thrombosis Forum. The North American Thrombosis Forum, NATF, is a nonprofit organization dedicated to improving the lives of those affected by blood clots and related disease. Through our comprehensive resources and innovative programming, NATF strives to educate patients and healthcare providers about thrombosis and its complications. This program was supported by an educated grant from Jensen Scientific Affairs. I'm now pleased to introduce our first speaker, Dr. Judy Shao. Dr. Shao is an associate professor in the Division of Endocrinology and Metabolism and program director for the Bariatric Medicine Fellowship at the University of Ottawa. Dr. Shah is a general internist and medical director of Leaf Weight Management Clinic, which is a community-based multidisciplinary academic bariatric clinic in Ottawa, Ontario. Dr. Shah is dedicated to teaching clinicians on how to manage obesity and to reduce weight stigma and bias for people living with obesity. Dr. Shah is on the executive board for the Canadian Association of Bariatric Physicians and Surgeons and the lead author of the Post-Operatively Management for Bariatric Surgery chapter in the 2020 Canadian Obesity Clinical Practice Guidance. Dr. Shah will be providing an internist perspective in understanding obesity and its management. Thank you, Dr. Shah. I'll leave the floor to you.
Thank you so much, Dr. Wang. And so these are my disclosures. Second, all right. And so today, over the next 15 minutes, I'm going to give you a sense about the complexities of obesity and help you recognize that it truly is a chronic disease. We're also going to be talking about an approach that Canada actually has developed in terms of looking at treatment options for weight management. And I'll put it as a picture frame of 3 pillars and post. And then we're going to explore how you can address obesity management in your clinic or in your practice and the impact that weight bias has. And we're going to all do this within 15 minutes. So first of all, I just want to bring out a few concepts. Concept number 1 is, yes, traditionally, we recognize the definition of obesity based on the BMI. And I really want to point out the fact that, yeah, a lot of articles and studies based on BMI, criteria for treatment based on BMI. But in the end, really, BMI just tells you how big a person is and not necessarily how sick they are. And so one of the things in Canada, what we're trying to do from an obesity perspective is to get away from the number on the scale. And so we recognize that things like the waist circumference, which is essentially correlating to visceral adiposity, and that type of information can lead us to know whether this patient has comorbidities, such as diabetes or hypertension or fatty liver. And so getting away from that number is really meaning that obesity is a hyperadiposity that impairs health. And we use that BMI simply as a measurement. So that's number 1. Number 2 is let's recognize that obesity is a chronic disease and it is super complex. It is not just about an individual having to do certain things. The fact is that there are a number of factors that an individual doesn't control. We don't control our genetics, and we know that BMI variability is related at least 70% of the time to genetics. We don't control necessarily our society. Well, we don't necessarily control what's going on with COVID, for instance, and we know weight has gone up during this pandemic. But we do control our behaviors, and that will be part of that pillar and post model that I'll be showing you in a few minutes. Concept number 3 is to understand that there is a difficulty in terms of weight management, in that our bodies naturally try to defend the higher weight that we had been at one point. And that's just a mechanism of defense, of survival, a genetic programming. And so what happens when a person loses weight? Well, there are 2 major things that can occur. One is metabolic adaptation, where our basic metabolic rate decreases. And then there's these hormonal signalings that occur, where those hormones that are supposed to make us feel more full actually decrease. And the hormone that makes us feel more hungry increases. So when a person loses weight and tells you that they're hungry or that they're craving for food, that's actually a natural defense mechanism that the body is undergoing. Concept number 4 is, what is success in weight management? And really what we try to do in Canada, at least, is to get away from the number on the scale. That being said, many people look at the scale and they think, is that a win or not a win? So one thing to bring out in terms of success in weight management is acknowledging that there's a normal progression of weight over the years. And there's a natural course of weight gain, and that could be a pound a year. So what if I'm an individual and I'm starting at this weight, and I go through an intervention and I lose weight? Ideally, for long term, it'd be lovely if I'm keeping my weight steady and it's in that weight maintenance phase. But the realities are, and you can look at pretty much any study, curve goes down, curve goes up. And that slope, ideally, you want it to be as low as possible, but realities are it increases. And you can imagine the individual walking through those years and those months and that weight going up and the panic that might occur. And our job as a clinician is to let them know they're still doing a good job. They're in fact still below their baseline. And even if they were to hit their baseline, they would still be below that weight that they could have been at had they not done an intervention from the beginning. Bottom line is, in weight management, weight maintenance is actually a win too. And so here I show you our pillar and post approach. What does that mean? So essentially we have here a roof or a post, and that post is diet and exercise, right? But diet and exercise doesn't work alone. It may be something that people concentrate on when they're looking at weight management, but it isn't the only answer. And essentially you need the pillars to help support you. And one of the pillars is that behavioral support, that psychological intervention. Then there's pharmacotherapy, and then there's bariatric surgery. So let's just break this down. What is diet and exercise? Often enough, it gets a bad name. People actually view the word diet as a 4-letter word nowadays. But really, it just means what's the nutritional profile that a person is doing. The word diet and exercise get a bad name simply from some of these presentations or these studies. This is a review that looked at different studies that over a year did lifestyle interventions for these individuals. And you see that people lost anywhere between 5 kilograms to 30 kilograms. And you're like, wow, that's great. They did terrific over the year. But the study went further to find out, what happened at the 4 or 7 year mark? And essentially, weight went back up. And the study essentially said, wow, why bother? It just fails. But in reality, going back to concept number 3, which is these people still remain below baseline. And in fact, I would argue did pretty well. So diet and exercise can work, but how can we keep that slope low? And so that would be when you start looking at those pillars. And one of the pillars can be pharmacotherapy. BMI criteria are used for pharmacotherapy in terms of who should be prescribed an anti-obesity medication. And so a lovely review that was just published in Nature Reviews, if you have a chance, goes over a whole bunch of pharmacotherapy that are available. And typically we see anywhere between a 5 to 10% weight loss. More recently, with semaglutide 2.4, we've actually seen double-digit % weight loss, which is quite exciting in the bariatric field. So anti-obesity medications can be that tool that can help a person manage weight. Notice, however, we're still not, according to this red line, anywhere near bariatric surgery, which you can see between 25 to 35% weight loss, depending on the intervention. I'm not going to go through each individual pharmacotherapy. That'd be impossible to do in 15 minutes, but I do want to go through some important concepts. If this is something that you want to consider for your patient, these are the principles of anti-obesity medications. One, it's chronic therapy. Obesity is a chronic disease. So just like diabetes, if somebody were to go on a diet and their sugars were still high, I would prescribe pharmacotherapy, and they would likely have to be on it long term. And that is similar with anti-obesity medications. Number 2 is all of these studies with anti-obesity medications included some type of lifestyle intervention. And this is a very important thing. If you are considering prescribing a medication that will actually lower the hunger signals in a patient, you must make sure that they still eat. And it's not uncommon where I've seen that people have been prescribed anti-obesity medications, but not been informed about the lifestyle interventions that they need to do at the same time, and they undereat. Sure, the scale went down, but their energy levels are low, and their quality of life is actually not that great, and there's brain fog, etc. So we need to make sure that people still eat while on anti-obesity medications. How long do you remain on this in terms of whether or not it's a success or not? We usually suggest at least 12 weeks at the maximum dosage tolerated. And we also view anti-obesity medications, not just for weight loss, but also for weight maintenance. Perhaps I have a person who's done a program and they've lost weight, but now they're having those hunger signals. And that anti-obesity medication might be able to keep that slope down so that they actually can maintain the weight that they've lost. And then also remember that there can be super responders and non-responders to medications. And that can mean that some patients will lose a lot and some patients won't lose anything at all. And it isn't meaning that the patient failed. It just means that we haven't found the right treatment option for the patient. And just like with any other chronic disease, we do combination therapy with these medications. Let's talk about bariatric surgery, which, typically in the higher BMI categories, but lately we've been talking about BMI of greater than 30 with comorbidities that are uncontrolled. And these are the potential bariatric surgeries, which range from restrictive ones and restrictive that includes also a malabsorptive component. And usually the malabsorptive procedures have more percent weight loss. But it's really important to recognize that it's not, hey, go for surgery and I'm going to be fixed. You have to work hard at it and you have to have good nutrition. And particularly with the malabsorptive surgeries, you have to commit to taking vitamins for the rest of your life. Finally, I'm going to go through the last pillar, which is the psychological intervention. And I have to say, none of us expect you to become a psychologist to help manage weight management. But I want you to recognize the importance of the role of the brain. And if we were to compartmentalize the brain into a homeostatic section, which is where those hunger signals are regulated in the hypothalamus, the hedonistic component of our brain, the wanting and liking of food. Think of the last time, and it's been a while probably with the pandemic, that you went to a all-you-can-eat buffet and you're really full, but you still go to the dessert table. It's calling you. And then there's that executive function of our brain, which is where that behavioral intervention is needed. And if I were to put this even into a simpler way of understanding, you could consider that the homeostatic and that hedonistic component of the brain is what we call our caveman brain. Our caveman brain that's programmed for survival, that just wants to hunker down, not move, and eat high-dense caloric foods. Why? Because you'll survive that way. And our executive brain has to be turned on, right, to overcome that. Because let's face it, healthy behaviors are not easy to do. How often have you heard, I know what to do, but I don't do it? Essentially, what's going to make me choose the carrot instead of the carrot cake? Healthy behavior is hard. Why? Because I have to avoid pleasure, not have that piece of chocolate, have the apple instead. I have to accept pain. I'm going to take the stairs instead of the elevator. Do the things that take the most amount of effort. At the end of the day, I might as well prop my feet up on the couch or put on my sneakers and go for a walk. And all of this for living for the future, right? That unknown future, just to be healthy instead of just relaxing right now. I bring in the topic of weight bias because it really plays a role in how a person living with obesity accesses care and also is able to manage weight. We know that weight bias exists and it's everywhere. There are 3 types of bias. One that's explicit, of which many of us already know in the media about the fat shaming comments and so on, but it also exists in our healthcare communities. Just by our language alone, if you'll notice, I have talked about obesity, not as an adjective. A person has obesity. It's not an obese person. And please don't use the word morbidly obese person. And particularly when a person comes in and they have access to their chart nowadays, it is really hurtful that they're coming into a thrombosis clinic, for instance, and see the terminology morbidly obese person, etc. Implicit weight bias. In your own clinic, do you have chairs that are wide enough? Do you have a blood pressure cuff that can go comfortably around an arm and not have the word thigh on it? These are the types of implicit bias that exist. But I want to bring to your attention one of the most potent biases, which is internalized self-directed weight bias. And some of the most worst fat shamers that I know are the people who are actually living with obesity. The negative comments that they've ingrained with themselves makes it difficult for them to manage weight. If you had a thought you were a unicorn, would you believe it? So why would you believe when you have a thought that you're ugly or stupid or crazy or unlovable, or that you deserve to be fat, or that you're a loser? And so in Canada, we've developed an approach where you can talk to your patient about weight, and we call it the 5 A's. Ask, assess, advise, agree, and assist. The last 4 A's, many of us clinicians are quite good at. We can totally diagnose and we can totally get a history. But the A that's most important is the ask. There is always that gap in care where a clinician and a patient, that elephant in the room might be weight. And the most important way to kind of address that gap is to start the dialogue and asking permission. Would it be all right if we discuss your weight? Would you be interested in addressing your weight at this time? That is a soft way of opening that conversation so that we take away that bias that might exist. And finally, I'm going to talk about just goal setting. I know very much so that in clinics, often we might say, hey, you should be at this weight. Okay, well, definitely it's not based on a BMI of 25. At our clinic, we don't set number goals. We set behavioral goals. Think about it this way. What is more realistic? Me telling somebody, hey, today you're going to weigh 300 pounds or 150 kilos. Tomorrow you're going to weigh 100 kilos. And the day after, you're going to weigh 85 kilos. How realistic is that? Or is it better that today you drink more water? Tomorrow, I'm going to go for a walk. And the day after, I'm going to go to bed earlier. Behavioral goals is what we need to set for a patient, and that weight will fall somewhere. And we talk about SMART goals, and we talk about being 90% confident that you can do it. So these are the key points that I want to bring up, is that weight bias exists. It can actually be hurtful and impairing our ability to manage patients who have excess weight. Obesity is a chronic disease. If you believe it, that already brings down some of that bias. Okay? Treatment is not just about diet and exercise. There is a 3 pillars and post approach. And please ask your permission. Ask the patient permission to talk about weight rather than assuming that that person who's living in a bitter body coming into your clinic hasn't tried. And success in weight management goes beyond the scale. Let's look beyond the number and let's look for other positive outcomes that can occur with weight management. Thank you.
So next, I would like to introduce Dr. Erin Day. And Dr. Erin Day is going to talk about how I treat my patients with obesity and coronary cardiovascular disease, including atrial fibrillation, from a cardiologist perspective. Dr. Day graduated from the Yale School of Medicine and trained in internal medicine, cardiology, and vascular medicine at Brigham and Women's Hospital in Boston. He holds a Master of Science in Epidemiology degree from the Harvard School of Public Health. He is currently an investigator in the Vanderbilt Translational and Clinical Cardiovascular Research Center at Vanderbilt University Medical Center, where he also practices cardiology and vascular medicine. His research interests include the epidemiology, pathophysiology, diagnosis, treatment, and prevention of peripheral artery disease. I will hand it to you, Dr. Day.
Great. So thanks again for joining us this evening. As you heard, I'm a cardiologist and a vascular medicine specialist. And I'm going to talk a little bit on how I treat patients with a range of cardiovascular diseases in terms of anticoagulation. So here are my disclosures. And in terms of the format for this session, I'm going to first hit on some of the concerns about DOAC use in patients with obesity. I'll review some of the current data and guidelines. Then I'll talk about what I do in my own practice and also discuss some special situations and future directions in the field. So I think we all appreciate the growing prevalence of obesity, particularly in the US. These are data from our most recent cardiovascular epidemiology statement. Here we're looking at the prevalence of obesity by state. And you can see at the low end, states like Colorado, we have around 20 to 25% of patients with obesity, all the way up to around a third of patients in Tennessee, and even greater than that in surrounding states. So again, sort of at best, no matter where you're practicing, the patients in your state, probably 25 to 30% at least have obesity. And so it's critical that we better understand how to optimally treat these patients, of course, who have a large prevalence of cardiovascular disease as well. So some of the concerns about DOAC use, particularly in this patient population, relates to the dose. So do patients with higher body weight need a higher dose of the medication? So these are data, this is from the FDA label for apixaban. These are healthy patients at different body weights. They were given a single dose of apixaban, and we're looking at the peak concentration in the patient's blood. So first, we're looking at a high body weight patient, greater than 120 kilograms compared to average. And you can see they have a lower peak concentration. And then down here, we're looking at patients with a low body weight, compared to average, and they have a higher peak concentration. So again, as your body weight goes up after a single dose of apixaban, the peak concentration goes down. So again, this raised the concern about what's the optimal dose. And of course, this is not the typical patient we're seeing in our clinic. We're not talking about steady state changes over time when we're treating patients for many months and years. We're not thinking about other medications they may be on, other comorbidities. This is just a healthy individual after a single dose of the medication. And adding to the concern is that really within our large cardiovascular trials of the direct oral anticoagulants, we don't have a lot of patients with extremes of body weight. So here are the four major DOAC trials for venous thromboembolism. Again, with our four primary DOACs, dabigatran, rivaroxaban, apixaban, and edoxaban. And you can see just using a weight cutoff of 100 kilograms or 90 kilograms, relatively few patients meeting those criteria were in those trials. And again, this is not that high of a weight. 100 kilograms is around 220 pounds. We're not even talking about patients who are 300, 350, or 400 pounds. So again, this raised additional concern about what do we really know about this patient population when we're using these medications. And then in terms of other post hoc analyses, here we're looking at, again, some of our major DOAC trials, looking at our AFib trials. Even if we use a higher cutoff for weight, so a BMI of 36 or a higher weight cutoff of 120 kilograms, again, very few patients in these trials met those criteria. Same thing for venous thromboembolism. If you go back to our primary trial with rivaroxaban, we only had around 300 patients who had a weight greater than 120 kilograms. And along those lines, how effective are these medications compared to warfarin in these patients? And really, it's just difficult to say. And this is because we have so few patients. Again, so few patients in the trial themselves, very few events, meaning very few patients in these higher weight groups had thrombotic events, and very few had bleeding events. So it's very difficult to say, based on the clinical trial data, how DOACs stack up against things like warfarin. Now, fortunately, in recent years, we have some more observational data to help address this issue. First, we're looking at venous thromboembolism. These are patients from the VA. We had over 50,000 patients in this analysis, all of whom were treated with an anticoagulant, treated with either a direct oral anticoagulant or warfarin. And here on the left, we're looking at their risk of a second venous thromboembolism. Anything on this side means the risk favored a DOAC, and on this side, the risk favored warfarin. And you can see all the different weight categories, even with a weight greater than 140 kilogram at top, and then less than 60 kilograms at the bottom. Really, you don't see any significant group that favored warfarin in a statistically significant way. And you can see that some of the groups, like this one, actually favored DOACs. So in terms of preventing recurrence in this analysis, it didn't really seem to matter what your weight was. There was no clear signal that warfarin was better, despite weights up to 140 kilograms and above. Then when you move on to bleeding, actually the trend seemed to favor DOAC in every single group. Again, not all of these were statistically significant, but based on these, you can't say that warfarin was better than DOACs in the high body weight group in terms of recurrent VTE or bleeding. That was venous thromboembolism. What about atrial fibrillation? We also have some more recent data on this. These are around 35,000 patients from a single healthcare system, again, treated with a blood thinner for AFib. And they split patients up based on their weight. This is from underweight all the way up to higher grades of obesity. And again, anything below this line suggested that DOACs were better. And this line, above that line, was warfarin was better. And you can see that no matter what your body weight was, DOACs seem to be better in terms of ischemic stroke, bleeding, hemorrhagic stroke, and even mortality for most of the groups. Again, we're not seeing any problem with DOACs for patients with AFib based on this analysis. Here on the right, we again just looking at the underweight individuals compared to the highest group in terms of BMI, and seeing how they perform differently when they're treated with DOACs specifically. And again, we don't see a big difference in terms of stroke, bleeding, hemorrhagic stroke, And in looking at mortality, actually the obese group did better on DOACs than the underweight group. So again, for both VTE and AFib, in terms of our newer observational data, we don't see any clinical concerns with DOACs compared to warfarin. And then finally, up until now, I've been discussing therapeutic anticoagulation, full dose anticoagulation for things like venous thromboembolism and AFib. But what about low dose anticoagulation in addition to aspirin? So this is from the COMPASS trial. These are patients who had stable atherosclerotic disease. And this showed, the original trial showed that low dose rivaroxaban, just at 5 milligrams twice a day, plus aspirin was beneficial in terms of preventing recurrent events. So in this more recent analysis, they split up all the trial participants based on both BMI, with the highest group being a BMI greater than 30, as well as body weight, with a weight greater than 90. You can see no difference in terms of the benefit of the medication. All groups performed very similarly. No difference in terms of bleeding. So adding on the blood thinner, not surprisingly, increased your risk of bleeding, but that was consistent in all groups. So even with the low dose DOAC and aspirin, we're not seeing that the obese patient population is performing any differently than the other trial participants. And so I think all those data were very reassuring. I'm sure we're going to come back to these more recent ISTH guidelines later on in tonight's session. But I think given more recent clinical experience, ISTH did update their guidelines on DOAC use in patients with obesity. So again, for BMI up to 40 and a weight up to 120 kilograms, they recommended that all DOACs are appropriate, and there's no specific monitoring that needs to be done within this group. Now, for patients with higher weights, so again, we're looking at so above that 40 and above the 120, they recommended that you use either rivaroxaban or apixaban. And really the reason and of course, other options include warfarin, low molecular weight heparin, and fondaparinux. But in terms of the DOACs, they recommended rivaroxaban or apixaban. Just want to highlight that really some of that is because we have fewer data on things like dabigatran, edoxaban, and betrixaban, and we don't have full pharmacokinetic data on all of these on the FDA label as well. So there are more data overall for rivaroxaban and apixaban. That's why they were favored in this guideline. And then again, just to reiterate, they did not recommend following peak or trough DOAC levels. And really it's because we don't know what to do with those data if we have them, and sort of making up as we go. So it's better just to not have these at all and just focus on treating the patient. And really in terms of what I do in my own practice, I think it really mirrors these more recent guidelines. I generally favor DOACs over warfarin for all patients, including those with obesity, unless there's a very clear-cut indication for warfarin. Again, I'm favoring apixaban and rivaroxaban for those with obesity. I can say that I routinely use that low-dose rivaroxaban in addition to aspirin regimen in patients with obesity who either have stable atherosclerotic disease or after lower extremity revascularization, and also use standard doses without any sort of monitoring. Now, what about some special situations? Well, times where I may favor a DOAC. Certainly, if a patient comes in and we're having this discussion, if they are favoring a DOAC, I'm certainly not going to fight that. I think that's really better than nothing. Now, if I have a patient who is on warfarin and they are persistently coming in with a subtherapeutic or supratherapeutic INR, I'm going to try to recommend that they switch over to a DOAC. Because I think that they're not getting the full benefit of warfarin in that situation. How about for extended duration prophylaxis and venous thromboembolism? I think targeting a lower INR range is really very difficult, and I tend to favor a DOAC in that situation. Then times where I may favor warfarin. Well, if a patient is establishing care with me and they're already on warfarin and they're doing great, I'm probably not going to change it unless there's a very clear clinical reason we need to do that. If a patient has recurrent VTE on a DOAC, I typically will not switch to another DOAC, and I'll move to something like warfarin or low molecular weight heparin. One issue that comes up a fair amount is a left ventricular thrombus. We mostly have observational data on this topic, but a more recent analysis again suggests that warfarin may be superior to a DOAC, and my practice is typically to use warfarin in this situation. And then finally, antiphospholipid syndrome, especially those who are triple positive, I typically would favor warfarin over a DOAC for those patients. Now, we've talked about pharmacologic strategies to reduce thromboembolism risk in patients with things like AFib, VTE, and of course, with a background of obesity. I think it's important, especially within cardiology, to think about other strategies to reduce that risk. I'm going to hit on some of these. One, certainly in AFib, we know that the bulk of clots that lead to stroke or TIA arise in the left atrial appendage. And when patients undergo cardiac surgery, it's very easy to essentially occlude that or tie that off, that small anatomic area as part of the surgery. It takes a few minutes as part of the larger procedure. And we have a more recent trial with nearly 5,000 patients showing that doing that in patients who have AFib reduce their risk of stroke or systemic embolism during follow-up. And I think this has really become now the standard of care during cardiac surgery to take care of that in this patient population. So that's one thing to think about patients. Again, you're not getting them off anticoagulation necessarily, but you're going to reduce their risk long-term of stroke or TIA. Now, in terms of non-surgical options, again, we have several left atrial appendage occlusion devices that you can use. So again, percutaneously occluding that left atrial appendage. This is a more recent trial. These were high-risk patients who had AFib. They were high risk of bleeding as well as high risk of having a stroke. And they found that occluding the left atrial appendage with this percutaneous device was non-inferior to using a DOAC in this patient population. So really exciting that you may be able to get some of these high-risk patients safely off a blood thinner while still reducing their risk of their long-term risk of stroke from AFib. Now that's a high-risk patient group, again, not specific to obesity and certainly not specific to the very high body weights. We have multiple other studies that are ongoing looking at other patients. So patients who not only are ineligible for direct oral anticoagulant, but patients who are great candidates for direct oral anticoagulant, but maybe they would do just as well having this device implanted and not having to be on a medication. So I think in the coming years, this is increasingly going to be one of the options we're discussing with our patients. So just to summarize some of the key points, again, I want to acknowledge that our randomized trial data on DOACs in patients with obesity, especially those with a weight greater than 120 kilograms, are limited. Nonetheless, available data, especially in recent years, show no clear differences in obese versus normal weight patients. There's no clear role for routine drug monitoring with DOACs and obesity. And I think it's important to consider some of the non-pharmacologic strategies to mitigate the thromboembolism risk in select patients. Thank you.
Thank you, Dr. Dave, for the great talk. So the next, I'm going to share my screen. The next, I'm going to, I myself will be presenting on how I treat these patients with obesity and VT from a hematologist perspective. So these are my disclosure. So in the next 15 minutes or so, I would first discuss a little bit about correlation between obesity and VTE and really spend the majority of the time kind of reviewing data on using DOAC, particularly in patients with obesity and VTE. And a lot of it is kind of building upon on Dr. Day's talk. Some of them might have a little bit repetition, but hopefully by going through different angles can also kind of help to explain the material. And then again, we'll kind of go over and review the ISTH guidance again. So I'll start with the case, which again, we'll come back to this at the end. This is a real case that I actually just saw in clinic a few months ago. It's a 52-year-old guy, long-standing history of multiple sclerosis, and to a point that he's wheelchair bound at baseline. And he presented with a new onset of shortness of breath and chest pain, and was diagnosed, imaging proven to have bilateral PE, and he has no DVT symptoms, and Doppler also has no DVT. This patient otherwise has no personal or family history of VTE, and exam is otherwise unremarkable. Other than that, he is on the larger side. His weight is 151 kilo with BMI of 45. His laboratory results are otherwise unremarkable. Platelet and creatinine are normal. So the obvious question is in what anticoagulant should we treat him? So again, we'll come back to the case in the case and answer discussion. So Dr. Shah has mentioned this as well as Dr. Day, so I won't go on this too much more on the epidemiology, but I think it's very well known that obesity is rapidly increasing and continue to increase to be a health problem worldwide. A New England Journal paper about 2 years ago actually projected that by 2030, which is actually less than 10 years from now, 1 in 2 adults will have a BMI more than 30, and 1 in 4 will have what's defined as severe obesity, BMI more than 35. So these are quite astonishing statistics. And these, again, has been addressed, and I'm sure people are very familiar with, are the most common kind of classification from WHO for obesity. And overweight is BMI over 25, and obesity is BMI over 30. So there are actually multiple studies in the literature showing that obesity is a known risk factor for VTE, especially and it's for both first and recurrent VTE. The first VTE data really initially coming from this large populational-based epidemiology study in Netherlands. It's called the MEGA study. They really show that people with BMI more than 30 actually have about 2 to 3-fold increased risk of VTE compared to, and this is first VTE, compared to people with normal BMI. And just to give you a perspective on, for example, we do, you'll probably commonly hear about the one of the most commonly genetic clotting disorder, factor V Leiden. The heterozygous factor V Leiden actually has been talked about quite a lot, but turns out if you were to have that, the risk of recurrent VTE is also about 1.8-fold increase. So actually being obese actually give you even further increase of VTE, but which I don't think people have really thought about or talk about a lot. Now, other than, in addition to the first VTE, obesity is also a risk factor for recurrent VTE. And one of the risk predicting model that help us as clinicians to trying to risk predict the risk of recurrent VTE after an unprovoked VTE that we use quite a lot is something called main continuous HER2 risk score, because this score was derived and validated here locally in Ottawa by Dr. Mark Rogers a couple of years ago. So we use this quite a lot. And BMI more than 30 is actually one of the risk factors, and is incorporated in the risk prediction model. And because it's been shown to, again, increase the risk of VTE by about 2 to 3-fold compared to normal BMI. Now, again, Dr. Day has already alluded to that. Why are we so concerned about using an anticoagulant in obesity? Because in the traditional sense of anticoagulants, such as warfarin and lomogaheparin, there are data to show that increasing weight actually require an increasing dose of anticoagulant. In the warfarin era, as we all know, that we use INR to monitor, to titrate the dose. There are literature to show that dose needs to be increased with weight. In addition, for lomogaheparin, when you use a flat dose or fixed dose lomogaheparin, mainly for prophylactic setting, there's actually plenty of data, particularly in the bariatric perioperative setting, to show that there's an inverse relationship between anticoagulant level, which is the measure of the level of anticoagulant, relates to weight. So that's why at first, when DOAC was kind of really increasingly used, it's about 10 years ago, DOAC is a fixed dose for everybody, as we all know. So there's any concern whether it's just as effective. So back in the first ISTH guidance, that's International Society of Thrombosis and Hemostasis, actually back in 2016, actually suggest against DOAC use in patients over weight of 120 kilo or BMI over 40. Now, I should say that these cutoff is really not based on concrete data. This is really as per opinion, really not based on a lot of data other than these are the initial PK studies that Dr. Day actually alluded to on apixaban. Rivaroxaban also has a very similar study. So you can see, first of all, they are all healthy volunteers. So these are not patients. And the second of all, you can see that the number of patients in each studies are quite small, and again, they are only getting one dose of each. 10 milligram of rivaroxaban is actually prophylactic dose, as we all know, as compared to 10 milligram of apixaban is a therapeutic dose. But again, these are not accumulated doses just after one dose. And they look at these patients, all these volunteers got separated into 3 different weight groups, and they are all equally distributed, and then they have them take this one dose and then measuring their maximum concentration and area under the curve. So what I found interesting is apixaban, as Dr. They already alluded to, actually found to have about 30% lower Cmax as compared to rivaroxaban. There's actually no difference in Cmax or AUC in the high weight group. However, despite the difference in this PK data, the authors in both papers actually conclude that regardless that these reduction is still not clinically relevant. They actually conclude that the same dose can be used in the obese population. But again, this was back in the 2000s, and this is really one of the very few initial PK studies that we had. Again, these are based on healthy volunteers. Now, since then, we do have quite a few more like a drug level studies in large randomized controlled trial when they are when the DOAC was first compared against the warfarin. They to name a few, RELY study is the biggest compared to warfarin. For AFib population, they actually found that the bigotrin trough concentration is about 21% lower in those who are higher weight, those over 100 kilo, but they did not see a clinical outcome difference. Study results in rivaroxaban are a little mixed. Some show that there's no difference in their levels with higher weights. Some show that there is a lower dose. And then engage AFib TIMI 48 trial is the edoxaban comparing to warfarin in the AFib population. Again, they did not show any effect of BMI or on the anti-tangent level or clinical outcomes in a larger way in the edoxaban group. So you have already seen this. This is one of the review that we were participating in. So these are meta-analysis and kind of summary of the large randomized control trial for the VTE population to look at really the outcome directly comparing DOAC, different DOAC versus warfarin. I put it on here also again to let you see that first of all, the cutoff of obesity in all these trials are really considered quite low, 90 to 100 kilo by today's standard. So even though, yes, there's really no difference in efficacy and safety, as you can see in the numbers, but these are really not considered to be super obese from this standard. And also you can see that the cutoff is also quite variable in different studies. So that again contribute, I think most of us feel very comfortable with people maybe 100, 101 kilogram, but with the real million-dollar question is, what about the patient who are much heavier, 150 to 300 pounds? Is there any cutoff, or if there's any? So rivaroxaban, as Dr. Day alluded to, is really the only large phase 3 randomized control trial that actually have a post-hoc analysis. Again, it's post-hoc analysis, but in a higher way. So this is is from the same study. I just separated them into 100 kilo, more than 100 kilo, more than 120 kilo to show you. And as you can see, more than 120 kilo is really small population, total of 300 patients out of, the entire trial has more 8,000 patients. So, and they only show the efficacy outcome. They actually didn't show the safety outcome in this very small population. But you can see that again, just look at the number. The DOAC doesn't have pretty good comparable recurrent VT rate compared to warfarin. And again, this is the only randomized control trial that we have data in this relatively obese, more obese population. So then after that, there's actually a plethora of retrospective study really over the years, I would say since the first ISTH guidance in 2016, to really look at this question, whether DOAC compared to warfarin. So there are multiple meta-analysis by now, and I will show you two of them. One of them I was personally involved. This is the first one that's published a little earlier by Vicky May et al. They actually look at a BMI more than 30 population, but then particularly look at even more with more obesity, BMI more than 40 and weigh more than 120 kilo. Again, you can see this cutoff is really kind of stem from the initial ISTH guidance, not a magic cutoff in any situation. So you can see again, these are most of them are single center retrospective studies. So the number of patients are quite small, except for Spiralis et al. This is a large database analysis. That's why it's much bigger. But overall, there's no difference in VT recurrence in patients with obesity or even more significant obesity. That's talking about BMI more than 40 when you compare DOAC versus warfarin in the efficacy. And if anything, this study, this meta-analysis actually showed that there's potentially a reduced risk of major bleeding associated with DOAC. So our group was interested in looking at this and did an updated meta-analysis, and it was published recently in Thrombosis and Hemostasis in August 2021. So after thousands of screening through thousands of abstracts, we eventually included 23 studies for systematic review, and 15 of them have provided sufficient data for meta-analysis. We actually include both VT and AFib population, but for the purpose of this talk, I'll focus just on the VTE population. So these are the main outcome. You can see again, focus on the VTE population. We were able to, in the meta-analysis part, we were able to use some assumptions and calculate the risk of outcome in the incidence rate per 100% years outcome in the combined rate. So you can see that actually the number in the DOAC is about 3.8 per 100 person years as compared to VK or warfarin is actually even higher, about 6.8. And the major bleeding also is quite comparable, even if the number looks better. When we look at the incidence rate ratio, so directly compare those two in the studies that provide both at the same time, we actually found that the DOACs have a statistically significant reduction with the incidence rate ratio of 0.5, so about 40% reduction compared to warfarin in recurrent VTE. And in major bleeding is also a strong trend, about 30% or 32% reduction associated with DOAC compared to warfarin. But not statistically significant. But again, we're looking at quite small numbers. So in the retrospectives, that they are really the majority, made up the bulk of the literature that now we have right now in the really more obese population. Again, BMI more than 40 and weigh more than 120 kilo. However, and I would say that the old study did not really show concern of efficacy. If anything, there are some study, and overall, one of the meta-analysis I show you did show that there's actually decreased risk of bleeding compared associated with DOAC. However, I think we should be cautious about interpreting this data. And I also want to mention that the limitations. These are all retrospective data. So as you can imagine, the drug use is not randomized. So and as a matter of fact, a lot of there are some study actually did show that the warfarin groups, the people who are given warfarin, really tends to be sicker with more comorbidities, including higher BMI, the BMI more than 50. and more chronic kidney and liver disease, which is really not surprising, as this is, the clinicians are more comfortable with warfarin as warfarin's been around for longer. And also in patients with chronic kidney disease or liver dysfunction, we also are, there are certain cutoffs that always frowned upon. So, whether this can also contribute to the outcome is unknown, because it's really almost impossible to adjust for every single variables in the retrospective study. But I just want to point it out that we, so far, again, I agree, there's no concerning data, but we do need to interpret the data carefully, as the data are quite limited. So again, in general, there's really no significant concern of using DOAC in patients with obesity and VTE, but the data are really suboptimal. I do just want to bring up just a few food for thought. I agree that DOAC concentration really has not, so far, has not been shown to be clinically kind of relevant to or clinically applicable most of the times, especially in the VT population. I think there are some data actually show that it does correlate with clinical outcomes in the AFib population, but the VT population, we still need more data. But in the few studies that we have, that there are a few studies out there, they're all very small, like 30-something patient or no more than 100 patient. But it is interesting that we can start seeing some trend that I've seen, that the peak DOAC concentration actually in general is about 20 to 30%. There's one study is even 40% lower in the more obese population. However, the trough concentration is actually only, I think one study showed 5% of people are lower, but most of them are in this expected range. So could this be, somewhat explain why there's a lower bleeding risk or efficacy? I think it's unknown, and it's interesting to look. Okay. So you have already seen the ISTH guidance, the updated one that's presented in ISTH in July 2021, and it's already published in JTH. This is just a brief review that, yes, they suggest standard dose of rivaroxaban or apixaban regardless of weight, but not to use the big-chain edoxaban. And I should say that this ISTH guidance is actually particularly only in patients in VTE. They actually did not address AFib, but I will agree with that data, that the data is quite similar. The reason they again suggest not use the big-chain edoxaban is really not because there's a harmful, there's data to show harm. It's just there's no data, or there's very limited data according to the literature review. And they also suggest not to routinely follow DOAC levels in the general obese population. But it's interesting that this is actually the complete opposite of their 2016 recommendation, because in 2016, they actually recommend if you must use it, you should follow. So again, this is based on expert opinions, and we certainly need more data. So in summary, I hope I presented to you that obesity continues to become more prevalent, and it's associated with multiple comorbidity, and VT being one of them. Atrial fibrillation is another, and all of these are commonly used with anticoagulation. Therefore, the optimal use in anticoagulation is really quite important. And accumulating data, again, so far have not shown concerns of accuracy and safety of DOAC, but I would argue that particularly in the VT population, we do need more data, because so far the only randomized control trial and prospective data we have is that 300 patients in the very obese population in the Einstein study. So hopefully in the future we'll have more data. So without further ado, I'm going to introduce our last, but not the least, talk this evening is from Dr. Malcolm Robinson. And I'm very excited about this talk, and really appreciate Dr. Robinson is here to provide a bariatric surgeon's perspective on this issue. Dr. Robinson is the Vice Chairman of the Department of Surgery for Clinical Operations, Surgical Director of Perioperative Services, and Director of the Nutrition Support Service at Brigham and Women's Hospital in Boston. He's a graduate from Harvard Medical School and currently serves on the faculty at Harvard as an associate professor of surgery. He's a general surgeon with a specialty in bariatric surgery, which he has practiced for over 20 years. Dr. Robinson serves on several national committees, is an associate editor of Obesity Surgery, and routinely lectures nationally in topics of nutrition and critical care and bariatric surgery. Thank you, Dr. Robinson.
So thank you for having me this evening. I don't have any disclosures that are relevant to this presentation. And as stated earlier, what I'm going to focus on is talking about how I work with patients who are on therapeutic anticoagulants preoperatively who are to undergo bariatric surgery. And so I want to talk specifically about when and how to stop preoperative anticoagulation, when and how to resume anticoagulation post-op, and talk a little bit about dosing of anticoagulation post-op. And I want to echo what my colleagues have said, is that there's not a huge amount of data in this, and a lot of this is based on expert opinion, and we'll talk about this as we go along. So I wanted to start with just a little bit of an introduction of why this is particularly important to me as a bariatric surgeon and potentially others who are non-surgeons who are working with this population, either in a consultative or a support role. And this is one study that comes from our MBSA QIP data, which is the Metabolic Bariatric Surgery Accreditation and Quality Improvement Program. In addition to accrediting the Centers of Excellence in Bariatric Surgery, there's a large quality program that has a large database associated with it. And in this particular study, they looked specifically at bariatric surgical outcomes in patients on preoperative therapeutic anticoagulation in a large group of patients. You can see that they had a group of about 420,000 patients who weren't on preoperative anticoagulation, to which they compared it to about 11,000 patients who were on therapeutic anticoagulation. And I'm not going to go through all of the differences, but you can see there were a number of differences between the two groups, not surprisingly. Not unexpectedly, bleeding was significantly greater. There was about a fourfold increase in the risk of bleeding postoperatively. There was also a risk which wasn't quite as dramatic in venous thromboembolism. And having said that, the thing to note that although there was a statistically significant increase in death, the overall death rate was relatively low at being less than 1% or only 0.55%. So what these data tell one is that, yes, this patient population is at increased risk of bleeding, is at increased risk of thromboembolic disease, but is not a prohibitive risk for surgical intervention, as the death rate is relatively low. And when you compare bariatric surgical outcomes to people who go to undergo a non-surgical treatment of obesity, all of the data has shown that bariatric surgery is superior in terms of long-term survival, weight loss efficacy, durability, and resolution and prevention of weight-related comorbidities. So what does one do when he or she has to consider when and how to stop preoperative anticoagulation? Well, it depends somewhat on the type of anticoagulant and on the risk of thromboembolic event when off of the long-term anticoagulant. And this is some of the expert opinion that's been suggested by the American College of Chest Physicians, who state that in patients who require temporary interruption of warfarin or a vitamin K anticoagulant before surgery, it is recommended that this be stopped approximately 5 days before surgery. We have found, particularly in my practice as well, in our practice at Brigham Women's Hospital, that if you stop it shorter than this interval, that we do see increased risk of perioperative bleeding, as well as bleeding intraoperatively. And so we do try to stop it approximately 5 days in advance. If there are patients who are at high risk, for example, if they have a mechanical heart valve, then it's suggested that when you stop the anticoagulation, that there should be some bridging instead of no bridging during the interruption of a warfarin therapy. If, however, someone's at low risk for thromboembolic events, then it's suggested that there's no bridging. And so this is where I, as a bariatric surgeon, I really want to work with my colleagues in the consultation services, hematologists or cardiologists, to determine what the risk is, to get a good sense of whether we need to bridge or not to bridge. How about management of stopping of preoperative DOACs? Well, the thought is similar to that which I described for warfarin, but the interval at which you stop this is less than 5 days. It's generally in the neighborhood of 48 hours for all of the DOACs except for petrixaban, which is 4-day stop. But the principle is the same, that you want to hopefully get the long-term anticoagulant out of the blood system before the patient's operated on, to hopefully prevent issues with intraoperative or postoperative bleeding. So this is how I think about it, and this is how my colleagues think about it. First, you want to stop the long-term anticoagulation. You clearly don't want to operate on an anticoagulated patient. The next step is to, once they're off of their therapeutic long-term anticoagulation, is assess the risk of VTE. And based on that analysis of risk, that's how you determine whether or not you need to bridge. People who seem to be at low VTE risk during the interval between the time that you stop it and you operate on it don't require any bridge. You just stop the anticoagulant. If they're at moderate risk, then that's when we institute a bridge with therapeutic low molecular weight heparin, and enoxaparin is the classic one that we do, and then we stop at 24 hours of pre-op. And so what we're doing is lowering the time interval during which people are off of anticoagulation, but allows us to stop it in a relatively short period of time before we undergo surgery. In the rare patient who has a very high risk and they can't be bridged appropriately with low molecular weight heparin, then those are the patients that we admit to the hospital preoperatively and bridge with IV therapeutic heparin, and we stop 6 hours preoperatively. Now, once we stop the long-term anticoagulants and stop the bridging anticoagulants, if any are indicated, it should be noted that all bariatric patients should receive perioperative VTE prophylaxis, regardless of what you've done with the long-term anticoagulants. And so our standard protocol for VTE prophylaxis include several measures. That includes prophylactic doses of anticoagulant. A lot of what we use is low molecular weight heparin or enoxaparin before the skin incision, and continue postoperatively until long-term anticoagulant regimen is resumed is in effect. Occasionally, some people like to use preoperative unfractionated heparin, but a lot of people will prefer the low molecular weight heparin. We combine this with intermittent pneumatic compression devices, and we strongly encourage early ambulation. So this take-home message is that even though you're stopping the therapeutic anticoagulation regimen, you do need to make sure that people are on a perioperative VTE prophylaxis. So let's talk about when and how to resume anticoagulation post-op. So it's very similar to the considerations that I talked about, what you do preoperatively. When you are considering what to do post-op, you want to have a very similar thought process. You continue that perioperative VTE prophylaxis, as I said. You resume the long-term anticoagulant regimen, generally 24 to 48 hours post-op, or I prefer to do it 48 hours post-op. It depends somewhat on how, quote unquote, dry the case was and what I viewed at the time of surgery. And then you want to assess the risk of VTE while the long-term anticoagulant is taking effect and has been resumed. And so if there's a low risk, then you don't really need a bridge. If there's a moderate risk, then we bridge with a therapeutic low molecular weight heparin. And then if they're at a very high risk, then we bridge with IV therapeutic heparin until we can get them on their long-term anticoagulant therapy. Also, that's important to consider is the dosing of anticoagulation post-op. And there's some considerations, particularly for warfarin. Vitamin K intake decreases immediately and dramatically after surgical intervention. There's also significant decrease in weight over time. And it's also to be noted the pharmacokinetics of DOACs, as we have talked about before, is poorly studied in obese individuals, particularly people who are undergoing bariatric surgery. So I want to take a minute to talk about warfarin dose after bariatric surgery. I have personally seen patients who go to back to their PCPs outside of our hospital, Brigham Women's Hospital, who are put on their preoperative doses of warfarin. And then I get a call that their INR is 6 or 7. And this is one data that's looked at this. And so this is a group of patients that looked at a bariatric group with a control group of surgical patients. And you can see that the mean weekly warfarin dose was higher, not unexpectedly, in the bariatric surgical populations, which weigh more, compared to the control non-bariatric surgical patients. The INR preoperative filia was in the appropriate therapeutic range, around 2.5 or so. You can see with the control non-bariatric surgical group that postoperatively their amount of warfarin that they took stayed about the same, and their INR level stayed within range. This is in contrast to the bariatric group, where you can see that despite dropping the warfarin dose, and in some cases very dramatically, there was still a sharp increase in the INR. And that you can see ultimately, and this is relatively shortly after surgery, so only 3 weeks after surgery, you can see a 30% decrease in the mean weekly warfarin dose. And with that, you can get the dosing, you get the INR level back in the therapeutic range. Interestingly, at a year level, when weight loss is stabilized or people are regaining it, you can see the mean goes up, but not to the preoperative level. So it's important that this is monitored very closely postoperatively. So what is the recommendation? And so there has been some evolution and thought on this, and I'm just going to talk a little bit about this. And this is from the American Journal of Medicine in 2017. They recommended the use of vitamin K antagonist warfarin rather than DOACs in patients who require 4-dose anticoagulation after bariatric surgery. And this is largely related to the paucity of data looking at this. They suggest that if DOACs are used in a patient at the bariatric surgery, that there's some checking of drug-specific peak and trough levels. And if these levels are found to be below or above the expected range, then they suggest changing to warfarin. Now, as we talked about, and as some of my colleagues have already addressed earlier in the evening, we are becoming more comfortable with the use of DOACs in patients who are undergoing bariatric surgery, for example, in atrial fibrillation. And so this is a more recent article in the American Journal of Cardiology looking at patients comparing non-bariatric to bariatric surgical patients and looking at stroke or systemic embolization, bleeding, or death. And you can see there's no statistical difference between the groups. How about if you were to compare DOAC use to warfarin use? So similarly, there does not seem to be a statistically significant difference in a stroke or systemic embolization, bleeding, or a death when you compare DOACs to warfarin. And this is a more recent abstract in the Journal of American College of Cardiology. This was published in 2021. And when they did their systemic review and meta-analysis, no significant increased risk of bleeding or systemic embolism compared to enoxaparin or warfarin. And they found that patients with apixaban achieved acceptable Tmax drug levels 100% of the time. So generally, the recommendations are for people who are in that severe obesity category that you want to use with caution rivaroxaban or apixaban, but avoid the other DOACs. And I'll conclude by saying Bariatric patients who require preoperative therapeutic anticoagulation are at increased risk of postoperative complications. But having said that, they are not at a prohibitive risk and still should be considered, assuming there are no other contraindications, to undergoing bariatric surgery for treatment of their obesity. These patients, however, require careful risk assessment and management of their perioperative anticoagulation regimen. They can be challenging. They are at increased risk of complications, and so they need to be managed carefully in the perioperative period. And the postoperative management of anticoagulants can be as complicated as pre-op, and therefore there are significant perioperative considerations that need to be made.
So I'm now pleased I will hand the program over to Dr. Alan Taylor, and who will moderate the panel discussion. Dr. Taylor is a chairman of cardiology at MedStar Heart and Vascular Institute, including MedStar Georgetown University Hospital and MedStar Washington Hospital Center in Washington, D.C. Dr. Taylor is a cardiologist and clinical researcher specializing in cardiovascular imaging and prevention, and has published more than 200 manuscripts in major journals. Thank you, Dr. Taylor, for moderating the session for us tonight. And I also want to thank all the speakers.
Yeah, thank you, Dr. Wang. Again, I'll also thank the speakers, and Malcolm, great job. So many good insights there in a complex patient population. And thank all the attendees for sticking with us and learning along with us. So learning is about infusion of knowledge and then about application. So let's move now to application, and we'll go through 3 quick case presentations with a moderated discussion. So let's start with back to Dr. Aday, and Dr. Aday will present a case of DOAC use in a patient with obesity and atrial fibrillation. Aaron?
We'll jump right in. Same disclosures as the first presentation. So this is the patient who came to me to establish care. He's a 68-year-old man. He has a new diagnosis of atrial fibrillation. He was diagnosed in an urgent care clinic. They treated him with metoprolol and then said you should see a cardiologist to decide whether you should be treated with anticoagulation. In addition to his AFib, he has a history of hypertension and hyperlipidemia. At this point, he's on a full dose aspirin, metoprolol, lisinopril, and atorvastatin. He's a former smoker and has a history of cardiovascular disease later in life in his father. So when I saw him, he was 6'2" and around 330 pounds. So that's a BMI greater than 40. Normotensive. Really, his overall exam was pretty unremarkable. He was still in AFib, so his pulse was irregularly irregular, but otherwise no evidence of volume overload, no suggestion of structural cardiac disease on exam. Lungs were clear and no edema. So when I see these kinds of patients, there's a few things that are going through my head. One, what additional workup do I need before I decide whether you should be on anticoagulation and what type of anticoagulant I would choose? And then, of course, what regimen I'd be using long term. And then for this patient in particular, I also want to think about antiplatelet therapy. He's already on a full dose aspirin. Is that something I want to continue, or should I be thinking about modifying that now that I'm moving forward, if I'm going to move forward with anticoagulation? So for him, I'll tell you that typically I want to get a basic metabolic panel because I want to know someone's renal function. That will impact which medication I use if I'm going to anticoagulate them. I think a baseline CBC is very helpful. If they have some sort of occult anemia, I may want to think about why they have that, and do I need to work that up before I'm putting them on an anticoagulant? And then, of course, I'll think about thyroid function for a patient with AFib. So he had a normal renal function, and really his CBC was unremarkable when I saw him. I want to think about structural heart disease. For this individual, he had a normal echo at that time. And of course, this was new AFib. He was mildly symptomatic. So for him, I was thinking about an elective cardioversion. Now, one reason that's important is because the immediate period after cardioversion, the first 30 days, it's a very high-risk period for thromboembolism. So I want to make sure a patient, they need to be on anticoagulation. And I also want to make sure they're going to stay on it. There are no barriers in terms of cost or things like that. I really want to be careful when I'm making that decision that I've got everything lined up in terms of their blood thinner. Now, for this individual, he was very adamant. He did not want a direct oral anticoagulant. He wanted warfarin. He was a little uneasy on what he viewed were newer medications. So now the question is, okay, if I'm going to put him on warfarin, does he need to be bridged? We've talked about this in another clinical setting. For him, he's 330 pounds. If I'm going to use low molecular weight heparin, what dose? How would I monitor that? And actually, I'll open this up to the panel quickly, especially for the hematology perspective. In an obese individual, again, 330 pounds, low molecular weight heparin, how do you think about dosing for that, monitoring? I often reach out to my hematology colleagues for guidance on this. I'd love to hear your input.
Good question. Dr. Wang, what do you do?
Yeah, so that's a very great question, and we don't really have a lot of data. So I'm probably speaking from personal experience. That when you look at the package guideline, I think in the United States, so Canada is a little different because we have a little bit more different kinds of lomocaparin. But in the United States, it's just usually just enoxaparin, and the packaging insert actually tells you are not supposed to cap the dose. But my experience is in this antidote, and it's not everybody. Some obese patient you dose by weight, and regardless of the weight, and they do just fine. But I do have quite a few patients when their weight, I would say when we start getting to like 120 milligrams or 120 kilo twice a day is a therapeutic dose, or this patient is 150 kilo. So I certainly have seen them have way more bleeding complication, especially patient will come back. They literally, the entire abdomen would be black and blue. And I've measured NITN level, which we don't routinely do, but I have measured NITN level occasionally on those patients. And my experience, their NITN level is almost always off the chart. And then we reduce the dose based on NITN level. And I always have to reduce those by like a significant amount, 20 to 40%. So what I usually do is, again, I would say this is based on no data, but I have had good luck that, for example, I do have a patient I can remember about 6 months ago, new diagnosis of colon cancer. So we decided he's 150 kilo. I think there's some reason we couldn't do DOAC. So then what we did is I actually just used 120 milligram. And then after 4 doses, check at NITN level, and he's right on target, and he did just fine. So for those people who are really significant obese, I probably will use a lesser dose to start with, but then monitor NITN level to adjust based on that.
Yeah, I agree with that. I would say the first question is always, do you bridge or not? And I think that's Aaron could comment, but I think that bridging is falling out of favor in many scenarios. Atrial fibrillation is one of them, except for extreme high CHA2DS2-VASc scores. How to determine high VTE risk versus low VTE risk, as Dr. Robinson alluded to. And for most AFib patients, it would be decided by a CHA2DS2-VASc score. The bridge trial didn't include CHA2DS2-VASc scores of 6 and above. But for lower CHA2DS2-VASc scores, bridging is not acceptable. It's more dangerous than it provides any efficacy. And I agree with Dr. Wang. The package insert for enoxaparin above 110 kilos is unclear, and I've had serious bleeding consequences. And Dr. Robinson, a recent case of mine, a fellow who I referred for bariatric surgery, he had an aortic valve. I recommended no bridging because he was a low VTE risk patient, although he had a prosthetic aortic valve. But post-op, he wound up on low molecular weight heparin at a dose of 150 BID and had a life-threatening bleed because of that. When I don't even think he needed bridging, but then we should, if we do need to bridge and they're a high risk patient, then I think you've got to monitor anti-10A levels. You can't just do weight-based dosing. That's my take on this, having looked at this and quite recently because of this one particular patient.
Yeah, so I was going to echo exactly what you, Dr. Taylor, and Dr. Wang were saying, that our personal practice, because we do see a fair number of these patients, and our arbitrary cutoff is that once you get above 120 kilograms, that we really shy away from doing a 1 milligram per kilogram BID dosing regimen. And we routinely get factor 10A levels. And I have not had a patient that is above that who requires, 120 or actually ends up requiring 1 milligram per kilogram BID. They always require less. And I agree with you, Dr. Wang. I have definitely seen abdominal wall hematomas, rectus sheath hematomas, related to that, and so I shy away from that. At some point, we should probably talk about antiplatelet therapy, but I'm not sure that that's out of scope or within scope. But continuing aspirin and things of that sort.
So back to Dr. Aday.
Yeah, so on antiplatelet therapy, for this individual, I would recommend stopping it. He was on aspirin. First, he was on a full dose aspirin. No clear reason he needed to be on a full dose versus a baby aspirin. But once I'm starting therapeutic anticoagulation, he had no clinical history of other cardiovascular diseases. He doesn't have a history of stroke, myocardial infarction. So I think keeping him on aspirin plus anticoagulation only increases risk of bleeding without a clear cardiovascular benefit. So this is a great example of reducing other therapies that were for primary prevention and just keeping them on things that they need moving forward. I think the discussions highlighted the issues with warfarin and bridging in this patient population. I agree. I try to avoid it if at all possible. For him, with the cardioversion, they unfortunately have to be therapeutic on anticoagulation before they're going to get it. So he was in a situation where, unless we could wait, he had to be on the low molecular weight heparin starting out. I do the same thing. I typically underdose, shooting more for that, not above 120 milligrams twice a day, and then 10A monitoring. So for him, he was therapeutic. He had his cardioversion. Then he came back a few weeks later. His INR has really not been in range. So what I do at this point, I will tell you that, of course, it's up to the patient ultimately. But this is an individual where I said, we're just at the tail end of this high risk period after a cardioversion. I'm worried about his stroke risk, and he's failed this trial. I know it's only been 4 weeks, but I'm not happy with that INR range. And I, again, would really counsel the patient at this point. So I really think you're going to do better on a direct oral anticoagulant where we're just playing with fire. Then that would be my typical, those would be my concerns at that point. So I did convince him. We switched to a DOAC. He did well for many years. He had a small myocardial infarction in the future. You could do an entire CME event on how we use antiplatelet therapy plus anticoagulation following MI. But for this situation, he was treated with aspirin, clopidogrel, and Eliquis for 1 month, and then just clopidogrel and Eliquis. Now, the issue for him is a year later, he had an upper GI bleed. It was a significant bleed. He required transfusion. He had upper endoscopy. They showed gastritis, but really no culprit vessel that they could intervene on. So, this is the patient that comes back to me in clinic. They're now off anticoagulation. What am I going to do? He has a very real history of coronary disease with a prior MI and a prior stent. So clear indication for some sort of antiplatelet therapy. He also has a history of AFib and has a very real stroke risk moving forward. What am I going to do? I think that for me in the clinic, one thing that makes me concerned is that he had this upper GI bleed without any clear intervention for us. So if we had a culprit vessel where we could have treated, I would be more comfortable. You could always think about starting a PPI in this individual, but it makes me nervous long term. We haven't really done anything. I'm not comfortable that nothing will happen again in the future. I guess I'll open up discussion quickly. Any other thoughts or strategies the panel will think about for this individual? And then I could share what I did for him ultimately.
Yeah, this may be somebody you think about a left atrial appendage occlusion device, and then just continuing P2Y12 inhibitor for the atherosclerotic disease that he has as a way to really optimize his safety moving forward.
Exactly. That's exactly what it did for him. I think at this point he has clear indication for antiplatelet and antithrombotic therapy. We haven't done much to reduce his future bleeding risk. I would think strongly about recommending that procedure and then reducing his regimen down. So perfect. And I think that's all I had for this case.
Great. Well, Dr. Wang, there was another question related to the relative safety of DOACs across BMI and high BMI patients, obese patients, or patients with obesity. Can you could you comment on that for the questioner, Dr. Wang, the relative safety of DOACs across the available compounds? PK/PD data, bleeding data in real world, the different DOAC choices that patients may have who are also obese.
Okay. The PK and PD data really is, the initial, the study that I showed you, those two studies in the healthy volunteers. And then the majority of the drug level data correlating with clinical outcome is really in the AFib population. So you bring up a really good point. There's actually very minimum in the VT population. The few that I mentioned about they're looking at their trough and peak, that's literally all we have. And I think overall it's like 3 studies. And for some reason, they all look at, the majority of them is looking at rivaroxaban with a bit more with the Pixaban, and they're all retrospective. They're all single center, and they are all, again, no more than 100 patients. And really, what I've shown in the slides is literally what they have. So I think UK have the biggest study. It's kind of looking at a range of BMI, so addressing the question of is there any BMI cutoff. We really don't know. So in the UK study, they have this, what they call it population based, but it's still not big. But they basically take all comer with all the different BMI. They just, measure all their levels. They use it in the 10 levels, and then trying to plot up the plot. They really didn't see a difference, as regards to BMI. So that's why when you look at the updated ISTH guidance, they actually took out, for at least for rivaroxaban and Pixaban, they took out any weight or BMI limitation or limit. That's really quite different compared to their initial 2016 guidelines that they artificially set this 120 kilogram and 40 BMI of 40. And that's also why you see the majority of literature using the 120 and 40. That's really not based on really any data other than it's from the artificial pick from the ISTH in the beginning. So I hope that answers some. Now I just want to address really quickly about compare, DOAC for different DOAC. I think somebody mentioned why do we all think Pixaban is safer? We really don't have data. You're right. There's absolutely no head-to-head comparison. That's a prospective randomized control trial that's considered a gold standard. There is one currently ongoing right now because our center is leading that. It's called the COBRA study. It's comparing rivaroxaban versus a Pixaban in the acute VT setting. There's a AFib study that we're trying to get funding. Now my colleagues trying to get funding. It's called COBRA AFib study. Very similar design comparing rivaroxaban versus a Pixaban in the AFib population. So hopefully, and then these are a very large study, 3,000 patient study. So it will take quite a while to finish, but we don't have a lot of data right now. Hopefully in the future we will. I will say that I think, me included, a lot of clinicians feel like a Pixaban, quote unquote, may be safer. Some people argue a Pixaban company probably did a really good job marketing their drug, and their large clinical trial comparing to warfarin does choose a quote unquote safe, better population, so their outcome looks a little better. If you do cross-trial comparison, which we're not supposed to, but people do it all the time. Sometimes I feel more comfortable with a Pixaban, mainly because the renal clearance, that it goes down a little bit lower for the renal clearance. And I know in the United States, FDA even give a indication for dialysis, which we don't have here in Canada. So I personally still don't use it routinely in dialysis patient, but in the US, I think a lot of people feel more and more comfortable using that. So that may also contribute to why people feel it's quote unquote safer. But I totally agree, there's really no concrete data, and we just need more data.
Great. I would say that I think when it comes to choosing DOACs, it's important just to know the drugs you're using and become comfortable with them. There's with multiple drugs available, you can know them all or know one or two really well and know how to use them correctly. Well, you're hot and warmed up. Let's get good case, Dr. Day. Let's stick with you, Dr. Wang, to your case.
So yeah, it's the same case I show you, and it's a real case. And it's it doesn't have a lot of detail, as many details as Dr. Day had, but it's a similar idea. So this is a real case, 52-year-old guy, basically came in to see me because he had a unprovoked. I mean, we consider this unprovoked, even though he does have relatively wheelchair bound, but that's something that will not be corrected in the future because he does have quite significant multiple sclerosis. So unprovoked PE, no DVT. First event, he's a guy, and he's only 52. His weight is 151 kilogram, so it's about 330 pounds as well, and BMI is 45. Other labs are really quite unremarkable. So this patient, again, going back to what's the cutoff, I personally, when the ICH guidelines first came out, we just kind of follow that and use the 120 and 40. And then, as the experience accumulating, I really feel like 120 and 40 is probably it's probably too low, quote unquote. So we start pushing our limit, and then we got the trainees ask us all the time, then do you have a limit? And I always say that I don't have any data. Certainly, the more obese these patients get, the lesser of the data we have. We do have some retrospective study, again, retrospective data to show that more higher weight, more than 150 kilo, BMI more than 50. I think there's a question about what about BMI more than 50? We have some retrospective data, very limited, showing that they, again, have no efficacy or safety concern with DOAC. So I would say that I don't know how to answer the question. I usually tell my trainees that I guess I don't know if I have any cutoff, but usually I'm quite comfortable until weight of 150 kilo. Go above that, and again, don't ask me why I picked that, but there's really no data. So beyond that, it's just a lot of people start feeling uncomfortable because it's such a limited data. So I do discuss with patient about the limitation that we have and in the little data we have, and then trying to have a good discussion and understand what would be the most feasible for them, because for some people, just like Dr. Day's patient does not really like quote unquote new medication, even though like this not technically not too new anymore, but some people still consider that relatively new. In some patient, I still have some patient who just wants the monitoring. That's still possible. So a lot of times we usually, in some patient still can't really, for whatever reason, can't make to the Wolverine clinic for INR monitoring. So that also is quite important about how their life will be on this anticoagulant. So usually we try to have a good discussion and then try to guide or help patient to come up with the decision. I would say this patient, because he's wheelchair bound and it's quite difficult for him to be making trips to labs for monitoring. So we eventually decided to use rivaroxaban, and it's been about 6 months, and he has been doing just fine. There's no recurrent VT or bleeding. So I myself also feel quite comfortable with using DOAC for the more obese patient. The one thing I still don't know is if there's a cutoff or not. So I think it's an individual discussion when it gets to that high.
Yeah, it's a good discussion. Dr. Shao, do you have any particular experience with these sort of recommendations in patients that you're seeing treating obesity and who come to you with questions? What anticoagulation should I take? I think the point of tonight is to make sure that we're identifying appropriate patients for anticoagulation. We're not shying away, regardless of obesity as a health concern, that the drugs are safe, but patients will still ask, which one should I take?
I think actually what I've learned from this conference is actually that it's so lovely that BMI is actually less of a concern, and that 120 kilograms that was so prevalent in the past is less so. So no, I don't actually get that exact question from patients, but typically I would get the scenario of this gentleman who's got MS in a wheelchair, and they'll be referred for weight loss, mainly because there's some concerns, right? And probably what I was trying to point out from my discussion would be, how do you address that? And do something say, hey, it would be good if you lost weight so that the anticoagulant would be very certain it would be working for you. How would you bring that up? And so in this case, in your conversation, you're detailing the safety. We're not quite sure when you're a certain weight. Would it be all right if we talked about your weight? And at that point, they might have an interest in this gentleman's case, it's only a few kilograms to bring down, right? So that's more where my role comes in. It's in terms of what to do when you have a person who is at a higher weight, and this might be a barrier to or a danger for their care.
Yeah. In the cardiology world, there's only a few indications where we still think that warfarin must be used, and those are prosthetic valves predominantly. And the rest, I think, the DOACs remain or are viable alternatives. There's a few controversial areas. Dr. Day kind of touched on one with left ventricular thrombus, but predominantly DOACs. And one of the things I worry about, and this is for group discussion in terms of which agent to choose in a patient, and this could be applied to any patient, including an obese patient, because some real world data does show that obese patients, outside clinical trials, do have more bleeding with warfarin. Is that as we use less and less warfarin, we get less and less good at it. The resources to run anticoagulation clinics diminish. The skill to manage it diminishes. And so we're fragmenting our clinical approaches, and that can sometimes lead to problems. So I wonder if others are thoughtful about that also, and trying to choose, direct acting drugs these days. You can't use them in heart valves, but like in atrial fibrillation, as Dr. Day said, it's really a drug of choice and these days.
Well, I was thinking the point about expertise is certainly true. I mean, when I'm covering, when I'm the overnight, physician covering the entire practice, and I get called with an INR of a certain range, and I'm trying to manage it, and they're living 3 hours away in a remote community. It's a little tough to know what to do with the INR, and can you track down an oral dose of vitamin K or all these kinds of things. I mean, it's really great if you can avoid those situations. That comes up quite a bit in my practice. And I do worry about the having the resources to kind of manage that in a larger network.
Yeah.
So I'm rarely using warfarin really clinically outside of those situations that you mentioned.
Now, and I have a question for Dr. Wang, and this is going to really you're going to really make your money on this one. One of the early concerns about DOACs was that they were non-reversible, but we have reversibility drugs now. Is there any evidence that can they be used in patients with obesity, just like in patients without obesity? These are the DOAC reversing agents.
The DOAC reversing agent, I to be honest, I personally haven't used quite a lot of them. It's actually one of them is actually not even approved in Canada, so it's not available here. But my understanding is they're dosed by weight, so I haven't really heard about, and I totally recognize it's probably very limited data because they haven't been used quite a lot. So, but I wasn't aware that weight would be a consideration. It hasn't been brought up. But one of the things, I remember when DOAC first came on the market, and a lot of patients say, "Oh, I don't want to use DOAC because of the lack of reversibility." I do want to emphasize that we usually try to educate the patient that really the lack of reversibility, I don't think it should make us shy away from using it, because DOAC in general, we do know that compared to warfarin, there's plenty of data to show they are safer. So I usually tell them that, look, we do want to have a safer drug and less bleeding to start with, rather than trying to worry about how to fix it. But again, long story short, I think going to your question, I don't think that weight would be a concern as far as I know to use those reversing agent.
Yeah, good one. Well, Dr. Robinson, we're going to end with your case. And,
sure. Can I ask you a quick question in terms of the reversing agents? Do you know if there's any data that looks at the risk of thromboembolic events on people who are off of all anticoagulants versus getting reversing agents? Do you become, in essence, hypercoagulable if you go on one of these reversing agents, if you see what I'm saying?
Yeah, if I may answer, I don't think we have any data because all those reversing agents, even looking at the data, they are all they obviously are not randomized. Like I should say, a lot of them are because of the clinical situation. You can't really randomize them to placebo versus the drug.
Right.
So it is true that they are Nexa, so that's the name that I was forgetting. So it is true that they actually found to have a really high risk of thrombosis and bleed in mortality actually within the first 30 days. But when people really dissect into the data, unfortunately, you can't really dissect out people who didn't restart versus people who restart. But I think the general consensus is these patients have a lot of thrombotic outcome because a lot of them didn't get restarted on anticoagulant. And the thoughts are it's the lack of anticoagulant that's making them have a lot more mortality and thrombosis. And whether they truly have a hypercoagulable state, I think that still needs to be investigated. I don't think we have a clear answer yet.
Good. So I just have a very short case, which is our very, very typical patient that we see undergoing bariatric surgery who is on preoperative anticoagulation. It's a 58-year-old female with a BMI of 42.3. So she has class 3 morbid obesity and does not need any weight-related conditions at all in order to qualify according to current guidelines for bariatric surgery. And she presented for a sleeve gastrectomy. She has a history of a pulmonary embolism of unknown etiology, and we see this a fair amount, and a family history of PE in her father. She did get a significant workup or a thorough workup for a hypercoagulable disorder and did not have one. And she is otherwise healthy. She's currently on rivaroxaban, 10 milligrams daily for secondary VTE prophylaxis. And so some of the questions that come to mind as a bariatric surgeon who sees this type of patient and that I work with my hematology and cardiology colleagues are when to stop this agent. Somebody already asked, and I think Dr. Taylor, you addressed this about how do you define risk during that period of time when you're off of the long-term anticoagulant and to bridge or not to bridge. I don't know whether people in their calculation of risk look at the time over which they are off of it. So like if you are on warfarin and are off of it for 5 days, does that make a difference in terms of your likelihood of bridging versus being on a DOAC for a day or two? And then of course, when you restart it, what you need to do in terms of either bridging or just restarting and dosing. One thing that I get drawn into as a bariatric surgeon, and it's certainly not an expert in dosing and monitoring these patients, is that patients will call me at 1 o'clock in the morning perioperatively to help manage their warfarin or their DOACs. And that's why I'm glad to have my colleagues at Brigham Women's Hospital. I think Dr. Day, you were there, so the people that I work with there. But those are some of the things that we consider. And then just the overall risk. And I think I'm hearing from you, Dr. Taylor, that the biggest risk group are the prosthetic valves, or at least the group that needs the warfarin or
Mitral.
prosthetic valve.
Yeah, mitral.
Right.
Well, they're both treated with warfarin, but the bridging is definitely in the mitral group. And a high risk aortic valve patient might be one who has perhaps prior thromboembolism from an aortic valve, history of endocarditis, prosthetic endocarditis treated, or maybe probably a recent AVR, aortic valve replacement surgery. There's a good question in here, Malcolm, and it's if a patient was taking rivaroxaban for AFib stroke prophylaxis pre-bariatric surgery, is there a concern after the bariatric surgery, given the importance of food on bioavailability and efficacy? And this is a question you might want to rely upon Dr. Wang for some of the pharmacokinetics, but also what you've done in your own experience for if DOACs concern you post-bariatric surgery when absorption of food and there's so many changes going on.
So it's interesting that you bring that up. So I rely heavily on my hematology and cardiology colleagues to help with that. But frankly, depending on the consult who's managing it, some people just give one dose, which is their preoperative dose, and continue that postoperatively. There are others who say that we're going to start at your preoperative dose, but as you lose weight, we may actually decrease your dose of DOAC. So not only with respect to warfarin is there some weight consideration, but with DOACs. And I have to admit that it varies by the hematologist or the cardiologist, and I'd be very interested in hearing what Dr. Ade and Dr. Wang and anyone else have to say about how they dose in a bariatric surgical patient who's going to be losing a lot of weight and losing it fairly quickly.
Dr. Wang, you're getting tough questions, but that's why we've got you here tonight. Any thoughts on this? It may just even have to be theoretical, the idea of post-bariatric surgery and bioavailability of the different drugs.
Yeah, I maybe still on the more conservative side. I do feel I have no problem with using DOAC in most patient with more obesity now, but bariatric population, post-bariatric population is one of the population. I'm still feeling a little bit uncomfortable, mainly because there's very limited data, and I do know that some people are using it, and we have some retrospective data saying, some of them, like Dr. Robinson was showing, didn't really show a concern. But I would argue that those data are still quite preliminary. We do know that for rivaroxaban is the DOAC that's known that you do need to have at least some food to have a good absorption. I think the PK study initially from the pharmaceutical company was saying that it's about at least 20% less of absorption without food. So say if we have a patient who had developed a recurrent VT while on rivaroxaban, the first question we always ask them is, did you take with food? So in that goes to, and also it also depends on what kind of bariatric surgery that you are performing and what kind of bypassing that you're doing to bypass the location of absorption. The reason I say that is because different DOACs actually absorbing in the different places. For example, rivaroxaban is more absorbed in stomach or lower part of stomach as compared to apixaban. Actually, 50% of apixaban is absorbed throughout the colon. So if a patient must use DOAC, that absolutely refuse to switch and stuff like that, and if they most commonly, I think nowadays has kind of gastric sleeve that you're bypassing the majority of the stomach. I think I personal preference probably will use apixaban, and I know that ISH guidance tells us not to follow an NATM level, but it's quite easy to follow, to at least check an NATM level here in our institution. So a lot of my colleagues, if they have to do that, they will. If they have to use DOAC in a post-bariatric surgery patient, they will. I should also mention just one last thing, that there are a few study, again, not great quality, but a few studies actually look at post-bariatric surgery and look at rivaroxaban 10 milligram versus 20 milligram. Is very interesting. They actually show that the 10 milligram, the dose that does not require food for absorption, have no change in their concentration, but while the 20 milligram actually has a decrease. So that's interesting in a sense. And these are all gastric sleeve patients. Again, the stomach was bypassed. So I think it's a complicated question. Unfortunately, I do think we need more data. But I personally are still a little bit more conservative in trying to discuss with the patient whether we truly feel comfortable with DOAC in this population.
That's an incredibly good answer and really rich information.
The other question I want to bring up for discussion is, how commonly do people use drug levels, DOAC drug levels? It was suggested, but I have to admit, I don't see a lot of that.
I think a lot of it depends on how available it is from your institution. It's not hard to do. It really is nice. It's the exact same way to do NATM level that you would have done for lomogapirin. However, each drug the lab needs to generate a calibration curve against each different DOAC. So that's the limiting step in my experience in the lab. Because before I came here to Canada, I actually practiced in the US for a couple of years. I knew in my own institution in Ohio, there's no availability of using DOAC, so we never checked it because it's not available. But here we do it in-house, and it's quite convenient. So then when it's available, then you just start using more. Whether that's helpful or not is another question.
Yeah, Evanisa asked if there were any ongoing PK studies after bariatric surgery, and sounds like we need them.
Mm-hmm.
There is an opportunity to use lower dose apixaban in certain scenarios, such as older age, reduced renal function, or low body weight. And in the high body weight patient who has other criteria such as older age and poor renal function, would you feel comfortable using the 2.5 milligram BID dose reduction in the setting of obesity? I haven't heard anything tonight that suggests that we wouldn't make that dose adjustment, but I wanted to get the group's thoughts on that.
I think that's a great question. I think that this patient does have some higher risk bleeding features in terms of the age and the renal function, and of course that renal function could vary, particularly at that age. I typically would use Eliquis or apixaban as my medication in that situation. I'd be fine either way. I guess I would say I'd probably go by the book and do the dose reduction. I can certainly see a situation where if they had additional high thromboembolic risk features that I think all of us have kind of teeter on the edge of that dose reduction or keeping at the same level in certain individuals. But I think overall I'd be comfortable using the dose reduction with Eliquis, with apixaban in that patient.
We've had a really full and excellent 2 hours, so I want to close the case discussions.